Hi. Welcome to Advent Health series on pulmonary hypertension under pressure. I'm Dr. Stacy Mandras, the Medical Director of the Pulmonary Hypertension Program at Advent Health Orlando, and I'm joined today by my friends and colleagues, Melissa Wilson, the nurse practitioner that helped build our practice, and Dr. Jason Stansberry, my pulmonary colleague and partner. Welcome. Today we're going to talk about risk assessment, which is becoming an increasingly important topic within the pulmonary hypertension community. Melissa, tell me a little bit about what risk assessment means to you.
So risk assessment is a great way for us to look forward at how our patients are doing. When we historically look at how our patients are responding to therapy or what their outcomes will be, really their survivability of pulmonary hypertension. Historically, we looked at what data was already done in the past, and then we respond to it reactively. The risk assessment allows us to look proactively at how our patients are doing, allow us to modify our treatment options for those patients to help improve their risk outcome, meaning the risk of survivability with pulmonary arterial hypertension in a year or 5 years.
Dr. Stansberry, when do you use risk assessment?
Well, we use risk assessment actually right from the beginning. As we first meet a patient and we establish the diagnosis of pulmonary hypertension, we want to see essentially how well controlled that their disease is or how severe it is at that point in time. So we use a risk assessment right at the beginning, and that helps guide our treatment choices. And then over time, we actually follow the results of our risk assessment at every follow-up visit to determine how well that a patient's responding to our treatments.
Melissa, what clinical variables go into risk assessment?
So there are multiple risk calculators for assessing the patient outcomes with pulmonary arterial hypertension. There's some that are the French, some that are Swedish models, and then the one that is most prominent and was based out of the largest registry done in the United States in pulmonary hypertension is the REVEAL registry. In our practice, we use the REVEAL risk score. There's 3 different versions: REVEAL 1.0, REVEAL 2.0, and REVEAL Lite. REVEAL 2.0 is the more commonly used calculator in present date, as well as the REVEAL Lite calculator. Things that go into the REVEAL 2.0 calculator includes the functional group, or the functional class of the patient subgroup. Do they have portal pulmonary hypertension associated with this or connective tissue disease? We look at the demographics. Is the patient male versus female? What their age is? Are they over 60 years old? What their renal function is like as well. We look at things like their blood pressure, their heart rate, as well as some hemodynamics, including the right atrial pressure and the pulmonary vascular resistance. We look at things that come off of the pulmonary function test, such as the DLCO. Also looking at pericardial effusions, is that present on their echocardiogram? Their NT-proBNP, and their 6-minute walk distance. And of course, something that goes into a lot of calculators for other disease states includes like all-cause hospitalization. So if a patient is hospitalized, they're going to get scored for that because we know that that's going to increase their risk of having bad outcomes. The second calculator that's utilized in our clinic is the REVEAL Lite 2 is what we call that one. And that uses less variables, because it's kind of great when you want to use it in between visits when you don't have fresh hemodynamics, for example, to add. So you're going to look at things like the NT-proBNP, the 6-minute walk distance, that patient's functional class, their blood pressure, heart rate, as well as their renal function.
So Dr. Stansberry, what do you do with this information?
Well, all of this information is really what we utilize to determine how well that the patient's responding to the therapies that we're providing. And as you just heard, it's quite a large quantity of information. So it really helps us to define how a patient is doing without using a lot of subjective things. We can take a lot of objective information, and we can really quantify how they're doing, how are they responding to the different treatments that we're providing, so that we can monitor that particular patient's trends over time. And it will guide, whether the patient would actually require an updated heart catheterization at a point in time, or if they're doing quite well, if we can continue to follow them with, non-invasive variables, because we really want to have the opportunity to provide the, right amount of treatment, the right amount of diagnostic testing, and provide the patient the best outcome possible. And collecting all this data for these individual patients really provides us a lot of assistance. So that we can do that, and we can really tailor everything to that individual patient, their individual risk profile, so we can know exactly what would benefit them the most.
I also look at it as a great way to modify our treatment plans. So I think there's always this group of patients. So when we get these scores, we look at them as low risk, intermediate risk, and high risk, right? So I think the high risk ones, we all very much so know what we need to do, how aggressive we need to be with treatments. But those patients in the middle are always the ones that always make you nervous, right? Because they kind of have one of two ways to go. Either they're going to get better or they get worse. So I think that risk score tends to help us understand, hey, this patient is not as well as we think they are. And so it allows us an opportunity to modify their treatment options so that we can help improve their risk score down to low, right? Because that's ultimately our goal.
And how do you explain this to patients?
So how I explain this to patients is I say what I've stated. We have so many different things we're looking at, right, as clinicians. We're looking at all these variables. We're looking at all these different tests. And we're taking all those things together and allowing us to kind of almost remove ourselves out of the equation of how I feel you're doing. It also allows the patients to remove themselves from how they think they're doing and allow us to collaborate together with this diagnostic test to say, how well are you really? And now I can use that information to say, hey, we got room to grow. So your 6-minute walk test is suboptimal, you're intermediate risk. Let's add another therapy perhaps. Or maybe this is an opportunity to say, let's go to pulmonary rehab, right? Because we got to think about all of our treatment modalities, and pulmonary rehab is a great one for that. So, is there an opportunity to improve that? Is it that your NT-proBNP is high because you're still using a lot of salt? So you can also use that to help motivate a patient to say, hey, you're at a 7, I would love to get you to a 6. Maybe we can work on cutting back your sodium and fluid intake, and we could perhaps get that BNP down in combination with working with our medical therapies, right? Our pills and, pharmacological treatments, that we can maybe get that down, and maybe that makes them modify like how they're thinking as well. And I find that patients tend to respond pretty well to that and get very curious, well, what's my risk score this time? And give them an opportunity to, I think, really be engaged in their healthcare. So I like to tell them it's a way for us to put it all together, put the puzzle together, and work towards making you better.
I 100% agree, Melissa. Well, I think that's about it for risk assessment today. Thank you so much for joining us, and we look forward to seeing you next time.